Today we are going to talk about scoliosis. We're going to look at the quick general aspects of scoliosis, because in our previous videos we've explained a little more about it. I want only to emphasize on some very important details that each therapist or each doctor that works with these patients must take into account. Recall that scoliosis can present either idiopathic causes or secondary causes. And, usually, the ones with idiopathic causes have two classifications, which are structural or postural. In the case of postural scoliosis, with exercise, and with the help of cordus or sacrus, the patient can evolve progressively until it is completely corrected. Structural scoliosis that has been completely established in a patient is characterized by the rotation of the vertebral bodies. In addition to a proper postural hygiene that the patient must keep for life, being very disciplined about it. Must also consider other preventive measures, such as good nutrition, good postural correction, good ergonomics, both at home and in the workplace. We can also help our patients with cordus and sacrus having frequent therapy sessions. And with this, we can progressively correct this deformity or progressively balance this deformity. Given the case we don't achieve a normal state. Remember that scoliosis can have approximately 3 to 4 degrees of curvature. The first and second degree can spontaneously withdraw, correcting towards normality. While the third and fourth degree, which occur when the fundamental angles, known as the angles of Cobb and Ferguson, are greater than 30 degrees. If this happens, then generally we are already talking about a third and fourth degree scoliosis. In order to treat these patients, it's very important to identify where the primary curvature is and where the secondary curvature is. Because the primary curvature is going to be the one that really presents the disease itself. The secondary curvature is formed or maybe is not. That is the case when we have a curvature in the form of a C. In this case, the secondary curvature does not exist. If we have a scoliosis in the form of an S, then the secondary curvature will exist, but it is not where the biomechanical problem falls, but instead, where the primary curvature is. How to identify a primary curvature? Remembering that in the radiography or any imaging study that we perform, we will find the signs. Looking at the rotation that is going to be present, approximately in all the spinous processes. Whereas we see that in the secondary or compensatory curvature the spinous processes are vertically aligned. In the primary curvature, they are rotated towards different sides. And the most important thing is that the therapeutic action of both cordus and sacrus will fall on primary points or, as they're called, the proximal and the distal end points of the curvature. We will recognize the upper point because it will be the first that is rotated towards the concavity of the curve. And the lower point would be the last spinous process that is rotated towards the concavity of the curve. And these are going to be the therapeutic points of greatest action, either with one or both instruments. Either with cordus or with sacrus. If this were a first or second degree curvature, the ideal instrument to work with is cordus. But if it were a curvature of third or fourth degree, especially a third degree one, we would begin the first sessions, the first months of treatment of this patient, with sacrus, placed fundamentally where the superior vertebra of the curvature and the inferior vertebra of the curvature are. Once we have managed to reduce from third degree scoliosis to second degree scoliosis, we would then begin to work directly with cordus. Cordus is going to have different actions. We are also going to work on the extreme vertebrae, but we also have to remember that we have to work on the apex vertebra. We recognize it as the vertebra where the curvature reached its maximum concavity, its maximum convexity. That is, the protruding vertebra or the vertex of the curvature. Therefore, here we are also going to work with cordus to correct and to align the spine. Remember, and it is very important, As the disease becomes chronic in the patient, all the musculature that is going to be on the side of the concavity is going to contract and shorten. Therefore, spasms will predominate in this area. Shortening of these muscles will predominate, therefore you have to stretch them because they do not have the same size as the muscles of the concavity, which become distended and laxer. And this is a phenomenon that occurs as scoliosis becomes chronic in patients. And it's an aspect that we must take into account when making therapeutic treatment. Another important aspect at the time of performing the treatment is fundamentally remembering. And I return and reiterate it and always emphasize that something important in the spine biomechanics is the sacrum. Remember that if we observe the scheme of this scoliosis, which is predominantly dorsal, if we have a look on the sacral bone, we find that it is misaligned and misplaced. Therefore, if I therapeutically work in this area, but I do not modify the sacrum, which is often the origin of the decompensation of the spine, if I don't work the sacrum, I will not achieve an optimal or effective therapeutic effect in this patient. Therefore, I always like to start my first therapy with these patients with scoliosis using sacrus, to start correcting the deformities that they have or the misalignment that the sacral bone has. Specifically, we can observe that it can be lateralized to one side or the other. And this will be much more marked when the patient has a discrepancy of the lower limbs. This means, a lower limb longer than the other one, which can normally be produced during the development process from childhood until reaching the stage of adolescence. Therefore, the most important thing, and it is an advice for doctors and therapists, is to start the work effect by always correcting the sacrum and then working the rest of the spine. And, in this way, a deeper and more effective therapeutic effect for patient control will be achieved. And I repeat, it is important that even if you do it in your practice, and you correct and help maintain the patient's proper posture, the patient must also do it at home, at least 2 or 3 times a week. These same exercises with sacrus and cordus to truly achieve a desired therapeutic effect. Let's remember basic treatment principles, both with cordus and with sacrus. If I start working with sacrus, then I start with my work at the level of the sacral region, later the cervical region, and finally the diaphragm. If I work with cordus, I would have to follow the cephalocaudal alignment, which is to start working aligning the whole spine from the atlas vertebrae to the cervical region, going through all the segments of the spine until it ends, and then focusing specifically on the region we are going to work on the patient. This patient is going to have a primary curvature at the lumbar level. This primary curvature at the lumbar level is being caused by a discrepancy of lower limbs and by poor postures that abound especially when standing, and gradually creating a curvature with a concavity. Let's say in this case, that the concavity is in the left side, and the convexity is in the right side. Therefore, if we have this curvature, we will notice that the spinous processes are going to be rotated towards the concavity. That means, towards the left side. It will have L5 as the lower vertebra of the curvature. And for the upper vertebra of the curvature, in this case, we will take T8 or T9. Therefore, once I did all the alignment and all the steps in the spine, I will place the patient with a cervical support, and a support at the level of the shoulder blades, and these will give postural comfort to the patient. But at the same time, it will help me to stabilize if there is any hump associated with the problem of scoliosis, and a support at the level of the sacral region, so that the patient has greater comfort when performing the treatment. Once you have finished with all the basic points in the patient, then we will place cordus in the specific points for this therapy. Let's remember that as the patient advances in the therapeutic sessions, And this patient, for example, has received 3 sessions where I made a general work in all the spine. I can now, starting from the 4th or 5th session if the patient has evolved favorably. But in addition to that, the patient complies with the exercises. Or performs any other type of exercises at home, or at a gym. Then we can already move on in the 4th or 5th session, to work directly on the curvature area. As I explained, the first thing we are going to look for is the superior vertebra of this curvature, which is the vertebra T8, T9. For that, I locate the xiphoid process. I trace a midline from the xiphoid process towards the dorsal zone, and specifically in this region we will find vertebrae T8 and T9. We will place the cordus there, specifically, as we already know, with side D facing up. We're going to put it in that position. And we're going to ask the patient to gently descend. Placing the shoulders on the support that we placed for the shoulder blades and keeping the support in the cervical region. We hold for 3 to 4 minutes. As we keep cordus in the upper vertebra of the curvature. After 3 or 4 minutes, we proceed to remove cordus. And we will incorporate the patient. Then we will go to look for the inferior vertebra of the curvature, which in this case we said it's L5 specifically. For this, we are going to ask the patient to place her legs flexed. Remember that if I locate the iliac crest and then follow a perpendicular line, I will find L4. Therefore I must go 2 fingers below that line. And I will find the L5 vertebra. In the case of the lower back, I'm going to work with the cordus side with the letter L, as we have explained before. I ask the patient to raise the hips. I remove the support. Look for the L4 region. I measure 2 fingers below, and there must be L5. I place it so that it is perpendicular to the spine and aligned with the curvature. And then I let the patient rest. To achieve a greater support surface, I am going to ask the patient to stretch their legs. And this way I will be helping in the correction of the spine. I can even use exercises during this therapy to help correct the spine. And I can start from the cervical region and perform movements to the side. Specifically, as we said that in this case, the concavity was to the left side. If I perform a forced rotation to the right side, I help the spine to stabilize and correct the deformity. And in the same manner, I can do light tractions of the spine by placing the thumbs under the lower angle of the jaw. And I do a slight traction and rotation. And in this way, I can be balancing the spine. Another exercise that we can use to help correct and straighten the curves is the following. As we said, if we have a concavity towards the left side, well, the most normal thing is that the left shoulder is lowered. And in this case, to help treat scoliosis, I'm going to ask the patient to place her arms in this position, keeping the right arm below and the left side at this level. This will help straighten and correct the spine. At the same time that cordus has an effect on the vertebral bodies. Having finished doing this exercise, I return the patient to the normal position. And then, as we said that in this case, L2 is the apex vertebra of the scoliotic curvature. So now I will treat the L2 vertebra, which is in the apex. And it is the last area to be treated. I ask the patient to bend her knees. If T8 is at the level of the xiphoid process, now we look for where the rib cage ends. I trace a straight line from the rib cage, and L3 is towards here. Therefore, 2 fingers up the rib cage the L2 vertebra is found. And now, we allow the patient to descend. We put a support in the sacral region. We ask the patient to stretch the legs. And we can repeat the previous exercise. Lifting the left arm again, which is on the side of the concavity. And in this way, we help to rectify the curvature even more. Therefore, the therapeutic effect will be much greater and more remarkable. We observe how, if we draw a line, we see the rib cage, how the left side rib cage that was more descended, has just risen. Once the 3 to 4 minutes are over, we return to the normal position. We bend the patient's knees again. We ask her to raise the hip, and we proceed to remove cordus. We can remove the supports. In this case, the one in the sacrum, also the support of the shoulder blades. But we leave the cervical support. And we can tell the patient to do Williams exercises for the lower back. In this case, the patient could perform the first Williams exercise. This is the way of doing it. Without moving the hip, she will raise the lumbar zone and then flatten it. And while doing this, she also has to contract the gluteal muscles. And this can be repeated several times. Crush. And contract. And this is going to help once cordus has already had its full effect on the intrinsic musculature of the spine. Because this will make it possible to gain strength from weak muscles and to stabilize muscle dynamics.